Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev. I'm from Kazakhstan, Almaty city. And my assistant Sheikh Meningioma, Mohammed Khan, and the operating nurse is Zoya. Anesthesiology team, anesthesiologist Aslıcan and anesthesiology nurse. And video support presented by Evgeny, video and company. And this is a case for streaming number 3 from Presidential Hospital Almaty. The full name of the hospital is National Hospital of the Presidential Affairs Medical Center of the Republic of Kazakhstan. Yes, hello. And patient under local anesthesia. Gentleman, young gentleman, 64 years old. Gentleman, previously operated in 1998, 27 years ago. And it was a craniotomy on the left side, left frontal parietal region, and was resection of the meningioma. I think it's a meningiomatosis, and some part of the meningioma still existing, and the patient started some symptoms with the hand weakness on the right side, and symptoms are progressing, and he has remaining hemiparesis on the right side. Так, много қайда тұр қазір? Много қайда тұр?
Қазір ма? Так, не подключично слева.
Okay. Sheikh Ahmed placed the guiding catheter in left subclavian territory. We asked anesthesiology team to give fentanyl for sedation and anesthesia. Lidocaine без кубик несешь ме? Check. И дым судженок несешь? И к шприцу. Yes, I'm asking. Now, Fubukima? Sheikh Ahmed? Fubukima? Yeah. Okay, Sheikh Ahmed starts with Fubuki. Which is not bad. Yes, the anatomy looks not bad. This is IC. Okay, before we will start, let's discuss. This is a right external carotid angiography. You can see the meningeal artery coming to the parasagittal region. And this is the main part of the tumor, the biggest part of the tumor. The IC territory is not supplying. It's a good sign that it's not atypical. It's a classical meningioma, and now we can see ophthalmic artery giving the meningeal supply, and the anterior meningeal artery is supplying to the middle meningeal, and we can occlude all this segment. we can go through the middle meningeal and we can occlude the anterior meningeal territory also. Yes, we will place the microcatheter here. Okay. Patient has a stenosis. Şeyh Ahmet, Berlin'de vermedin mi? Patient had an ICAT. And it's significant and it's... Битшіп, екі таблетка Берлинді аузына саласасыншы қазір. Аспирин ішіп жүр ма? Yes, it's critical stenosis. Yes, and the problem nowadays, we could not call the patient with the ICAT for the treatment through the tender. Tender is a quotation, and for treatment of this stenosis, patients should pay in our department. In different places, our colleagues are not doing the treatment. Option number 2, we can call the patient in a month for the treatment of the left side of the meningiomas and yes, yes, intracranial circulation is not involved. Mostly involved extracranial circulation. Meningeal branches here, here, and here. And also stenosis. The patient has a diabetes mellitus. It's not a nice comorbidity. And patient has a tinnitus on the right ear. Okay. Okay. Lidocaine is ready. Just a second. We will give 2 pills of Brilinta. Yes, there is a stenosis. Yes. Venous system looks good, but this is a stenosis. It might be cause of tinnitus. No, tinnitus не причина сволнка. Yes, on the right side it might be problem, and all venous drainage coming here. Yes. Meningiomatosis, left IC stenosis, and right jugular stenosis. Yes, and yes, it might be one of the cause of this problem. We can place stent transvenously. We can angioplasty with 5 mm balloon, and we can place the stent for this stenosis. It's 10 mm. Really 10 mm. Okay. Okay, let's see. We have a C-guard stent, and C-guard could be placed in this position. We also learned it about C-guard from Adnan Siddiqui. Let's see. Let's see. And everything under local anesthesia, with small sedation, with a slight sedation. Then there is the extracranial carotid stenosis.
Примите да?
Да, есть перестрой. Есть перегреб. Сол кезде тез сіңеді да. Ана қағазға ұрып или өзі шайнап жүрсін. Қазір 1 секунд. We'll give a Brilinta 2 pills. И сумен ішіп жүру керек. Так. We will work a little bit longer. Yes, initial plan for this streaming was a IC aneurysm, but this patient has a diabetes mellitus. That's why we decided to bring him to the angio suite first. Then we will do IC stenosis, IC aneurysm. Okay. This is stenotic artery, but still okay. I think here is a more significant stenosis. We will do angiography in 45 degree. Okay. Yes, the diabetes is changing the patient's life, and it's not a so nice disease. Yeah. Diabetes is disabling disease. Yeah? Social disease. Okay, social. Так, okay. On lateral view, it looks like stenosis is more significant in this projection, and after embolization we will do 3D angiography for this segment. Okay, it looks like it's bigger than on AP and lateral. Yes, and there is a ECA stenosis also, but it's not a big problem. It's not a problem at all. Okay. Jugular stenosis we will leave for the next time, and today's treatment I think we need to complete with the I think it's a meningeal artery. It looks like meningeal. It's already there. Okay, let's change the projection. Басын тура жатқыз деп айтасың. По стойке смирно жатсың.
Бейнені көріп тұрсыз ба, көз алдыңызда басыңыз тік болыңызшы, ровно. Соған қарасаң, ровно. Все болды.
Все, қимылдамаңыз. Қимылдамай жатыңыз. Бүйрек жаман емес қой, да? Поясишь смарт-маск? Все, отлично. Yes, we took a 7F short cheese, and through the short cheese we placed Fubuki 7F angled one, and through the Fubuki 7F now we are navigating headway dual 156 centimeter, which is our favorite microcatheter. At this point, the navigation of the microcatheter could be a little bit painful. Yes, I need to point my microcatheter to this branch. It's very important because this branch has supply with the as much as possible. We need to push the microcatheter. The micro is not going to the branch. I think it's a wedge position, and then it's good. Let's go. Yes, and important point, we need to control extracranial part also. It could be supply from the superficial temporal territory, and also we know about the ophthalmic artery territory. It's very important. Okay, I could not infuse all 4 cc of lidocaine in this branch. I will just give 2 cc, and 2 cc I will leave for the left side. It's a lidocaine. In syringe we have 4 cc, but I will give only 2. Demoso is squid tonic inhibitor. We have some squid 12, that's why we'll work with squid 12, but also we have one Menox 18. It's a problem, huh? It's a problem with the instrument delivery, and only emotions. There is no explanation. Okay, only the emotions. There is a contralateral flow. Аға бір 15 минут қозғалмай жата тұрыңыз, жақсы ма? Сәл-сәл ауырсынады, бірақ шыдаңыз. Narcos бермеу үшін ғой. Ашыр. It's very important. We didn't give a general anesthesia with this severe stenosis. Patient may experience stroke after the with the critical stenosis. I think with the diabetes and all these conditions, this patient should have also the coronary artery pathology also. Okay. It's a headway do, that's why I can give a little bit more reflux. Так жинеш. Сол шприцқа жинесің. Даем сон шприцна, сквит жинеш. Okay. Let's wait a bit. Тағы бір шприц набор аштырып дем содинайсаш? Отлично. Все хорошо. Yes, I'm asking Sheikh Ahmed to prepare the second stage with DMSO. It's a little bit longer reflux, that's why maybe we will need maybe we will need a DMSO at the end to proceed the liquid embolic dystally. Yes. Yes, septor mini or regular septor could be good option in the treatment of such a pathology, but navigation of septor could be a little bit problematic. There is a supply from the left side and it could be also supply from the soft tissue. That's why it's not going directly. As you can see, there is a supply from the trepanation side. Егер материал сатып бермейтін болса, пациенттерді жатқызбай қойған дұрыс шығар, наверное, да? Дұрыстап операция істемесең не керек ол жатқызып. Okay, now it's going to the branch, which also fills the meningioma territory. And the interesting part of meningeal supply, it's possible from one branch to fill the another territory. It's a point number 1. And point number 2, it's possible to from one side to fill the contralateral side. But now we didn't reach the territory of anterior meningeal branch. That's why we will continue. The anterior meningeal is more complex for catheterization. We need to go to the ophthalmic artery. That's why I will try to proceed from this point. Okay, let's wait a little bit. This patient is moving, but with such comorbidity, I will try to do it under anesthesia locale. Yes, usually with this kind of arterial supply, meningioma will grow. There is no doubt. It's mostly refluxing, then proceeding forward. Okay. Начнем режиссер. Стоп. Начнем колдон жинесің. Пока қиып тастайсың. Обратно қоясың. Yes, let's wait a little bit. And we noticed it's possible to inject with the delay more than 2 minutes if we use a headway duo or other kind of coiling microcatheter like headway 17 or echelon, and it's quite nice experience. There is some supply from extracranial to intracranial. Ар жақта менингиома жоқ, да, үлкен? Сол жағында. Yes, the meningiomas on the left side, most of them are small, not so large and big. Okay. Yes, meningiomatosis. It's a genetic changes. At one point, the artery may rupture, but I hope it will connect with the ophthalmic collaterals. I don't want to go to the ophthalmic territory, and it would be better if it will connect. I start to proceed. We need to wait a little bit. Draw from here. There is a slight supply from the ophthalmic territory. There is a small part of meningioma remaining. I think it will be better if it will go forward. Родно. Okay, now we will change the syringe for Demisol. If it will connect with the ophthalmic territory, it's better. Let's connect. Please connect. I don't want to go to the ophthalmic branches. Yes, now it's connecting. That's good. And then we shouldn't. Okay, now it's connected. That's good. Hmm? Yes, and it's very important to control the whole territory to avoid the ophthalmic artery embolization, which is possible in some conditions. Yes. Yes, at some point. There is the reflux, huh? Okay. Now we'll put some DMSO. Так, анаған қалдығын жинайсың. Okay, let's wait a little bit. Yes, it's very nice that we could disconnect the ophthalmic artery from the tumor. Ophthalmic artery branch now is disconnected and it's not more supplying the meningioma. Okay, now it's better. But that branch coming from that territory is also supplying something. Yeah? It's collateral. It's collateral, and at some point it's behaving. Трудно. Сейчас. It's a Shimon-Maimon's technique after injection of liquid embolic and stopping the distal penetration. It's possible to give some DMSO, and DMSO is starting to fill the territory. It's a prophylaxis of no, we'll try to retrieve it's retrieved. Okay, and it's complete. It's okay. Оникс хай температура пока. Оникс хай температура. Squid хай температура. Пока хлесом. Оны сложностьтен қойсын. Okay, let's check. Қозғалмаңыз. Бәрі жақсы болды. Қозғалмаңыз. Қозғалмаңыз. Yes, meningeal territory is clear. There is some spasm, but it's okay. Okay. At this point, I will ask Sheikh Ahmed to do control CT. Let's do control CT now, and then after control CT you will do 3D angiography from the ICA, yes? Okay. Let's place the guiding to the ICA. Yes. Now we're in the ICA. It's Fubuki, that's why I can do it like this. First of all, we will do control CT, and then аға қорқпай жата беріңіз. Бір жағын бітірдік. Сәл ауырады, қазір сәлден кейін қояды, жарайды ма? Қазір басылады. Ксифакам бере салыңыздаршы, 16 миллиграмм. Yes, there is some pain on the right side, and we asked for lornoxicam. It's non-steroid analgesics. And let's see. Сразу басываешь? Келсін. Баш жүре бер. Баса бер. Ұстап тұр қатты. Steady. Now it's working. I have no explanation why sometimes it works, sometimes it's not. But meningeal artery is also supplying the bony part. Okay, let's see. 3D қоя бер пока. Now we will do 3D array. Все, баса бер. There is one more meningioma, a little bit proximal. This is meningiomas on the right side and the left side meningiomas. Мынаны жаптық па? Мынаны. Okay. Let's check the 3D angiography. 3D істей берші. Қазір тұра тұр. 3D істей жүрсің. Now I can see the meningioma in Syndraan fissure. Okay. Okay. Ксифакам стегнул сзади? Okay. Okay, let's check. Let's see this meningioma. This meningioma is located here. We have this meningioma bigger, and here is also the meningioma. But we couldn't notice because it's not so big vascular supply. Huh? Okay, let's see. This. Okay, let's see. We already occluded this point, and maybe it will also devascularize. And now we have also the 3D. I think it's possible to follow, but this point looks more stenotic, huh? In this projection. Okay, let's measure. This point is stenotic. 1.7 millimeter, and it should be 386. It's more than 50%. Стенд сол жағына қоямыз ғой пока? Сол жағы больше сияқты, да? Не бере салшы? Xeon Blue. Okay, let's discuss about the next statement, but now we have this problem. Okay. Let's discuss the problem of next time. Окей. Екі жағында да стеноз деп жазасыз, но мынау стеноз 4-4 болу керек. Мына жерде 3 стенд қойсақ дұрыс болады, да? Yes, so it's more than 70% stenosis, and it's a linke Seite, left side. That's why we'll place the stent first here, and then we can continue with the embolization with the small meningiomas. Okay, let's check the meningiomas. Okay, let's count together. Here's no meningioma. This is meningioma number 1, but we already occluded the meningeal branch. We will see how it will be in 2 days. Then we worked on this territory. It's already occluded. And now we have a meningioma here, which is more frontal than it was before, and this both connected, and we have meningioma here. Okay. Yeah, this is quite attached to the brain. That's why we will work on this, and this one we will leave for the next time. Do you agree with me? Maybe. Yes, this is bigger and this is smaller. It's the left side. Yes, it's already occluded. We will see. And this is the left side. On the falx there is a meningioma, and I have seen this meningioma on control angio from the temporal artery. If you notice, you can see I think this one. You can see there is a connection here, then it's proceeding to intracranial circulation here, and this part, this is a meningioma. It's the remaining part, this part. Okay, let's see. This part is nearly 70% stenosis. On 3D, it's a little bit more stenosis than on 2D, but here those look like more significant stenosis, and here is a stenosis also. Okay. 3. 1.7. Okay, let's follow this part and we'll stent the left side. The stent will be 3 mm. Let's see what we have on the shelf. Гепарин 5 мың істей салшы. There's not so much. Екі жарым 18 көрсетесіз, мен көре салайын. Или бүйтесіз, кімдерге барып кардиологтардан 3 мм-лік 15 или 18 стент бере салсаңшы.
3-15 или 18, ба?
3-15 или 3-18. Любой стент. Оны ауыстырмай қой, орнына басқасын ала сал. Аға, басыңыздың ауырғаны шамалы басылды ма? Okay. Yes, now for less pain, less headaches. Huh? I think it's good. The catheter stayed too much in this territory, that's why I will check one more. Let's look okay. Yes, in 64 years old a gentleman, the anatomy is quite okay. That's why we can navigate with the Fubuki. Так, ана тамырларды қарайсаңшы, Шайхмет, сол жақ менингиальный боковой қойсын. Басында наружкадан жасаған әңге бар ғой. Yes, I'm asking Shaykh Ahmed to see the extracranial territory. I think it's possible to go with the once again with headway dual, or we need to take. Please put the zoom and see the distally. I think the headway dual will be okay. Huh? It should be okay. Тағы бір headway dual ашты осылай. Yes, it's intracranial circulation. Так, смарт мозг. Так, стенд келді ма? Навигейтке қойасың. Родный отпасы. Ультимастер ногами еще без. Морой, да? Окей. Гепарин без кетті ғой, да? На бұрышын. Now we asked for in the flutter. In the flutter. Шприц in the flutter. Манометр. Yes, usually at this point of time, at this part of the treatment, the team start tiring, and yes, I understand why, but we have one more case for today. That's why one more. I see aneurysm. Так что шаршама син шаршама. There is a Kazakh song. Don't tire. Шаршама син шаршама. Деген өлең бар ғой, да? Мынаны аласың, қазір тұра тұр. Қазір тұра тұр. Все, тарта бер. Шар жерсің. Жем. Кім айтады сол әлін? Шаршама сен шаршама. Назад тартып қойсың. Okay. It's a Xeon blue wire, which is coronary wire. And now we're a little bit distally to the stenosis, but I don't want to be so distal. because proximally we need to take part of stenosis. Okay, alright. Nominal 11 millimeter. 11 atmospheres. Okay.
6, 9, 10,
12, 13, 14. Напряжение var mı? 14, 15. Назад. Yes, we gave 15 atmospheres. At 15 atmospheres, the 3 millimeter Ultimaster Nagomi opens till 3.1 millimeter. At the measurement, the proximal part was nearly 3 millimeter, but the distal part was 4.4. But I don't need to take a risk of rupture, but it looks like we can give a little bit more. Now I will ask Sheikhmet to give 20 atmospheres. Дистальный жар жақсы, проксимальный. Конструктор. Ұрай бер. 24 бересіз. I ask Sheikhmet to give 24 atmospheres. Все, назад. Yes, now we finished with 24 atmospheres. Yes, it's good. I think it's enough, huh? We don't need the ideal picture, we need just decrease the percentage of stenosis. Yes, we can compare before and after. Балон лақтырасың. Индифлятор тана стол қойсың. Let's do it from common carotid. Yes, if we will call this patient only for the ICAT, then patient should pay in our department. But there is also stenosis in ICA. Yeah? If we will treat this ICA, then we couldn't go to the ECA territory. Okay, breath вперед. ICA we will leave for the follow-up. Назад. Stop. Okay, maybe next time we can treat this stenosis next time. Yes, again, thanks to Nurjan Suleiman Kulov, he started to use the coronary 14 wires for navigation of Fubuki, and he's my student, but I also can learn from Nurjan. It's very important, the close collaboration with your students, with your fellows and students. Yes, nobody is ideal. Какой-то щелик по танчан, наверное, нужен, да? Окей. Ол бағауыз емес қой, да? Щеликті. Қазақтың ыдысы ғой, да?
Бірінші сөз, шелектің алдындағы сөз енді.
Ол да әдеби сөз ол. Медициналық. Okay. Okay, it was a Kazakh joke. and I hope Nurjan will understand. Can dostum, İstanbul'un nereydi? Yes, it's a song about best friends. We sing that song at the Neradict in Almaty, in Astana with Rene. Okay. It's about friendship. Can dostum, it's my best friend. Yes, Nurjan is the best friend. Okay. The direct translation of the interpretation of the Can dostum is a soul mate, soul friend. Okay, there are two meningiomas, one in posterior part. I will leave the posterior part for the next treatment. Then we can treat the stenosis and also the meningioma. If we will treat all meningioma, then next time we couldn't treat the stenosis. Huh? Okay. And it's look like all of them supplying. Huh? Okay, let's we can proceed. This looks like it's a wedge position. Huh? At this point it's a little bit painful, but then headway stopped at the wedge position, which is good. Okay. Contrast. It's quite a big meningioma. Yes, and it could be a little bit painful. Фентанилдың дозасы максимально кетті ма? Тағы да істеуге болады ма? Или бағана жетеді ма? Yes, we're asking for a little bit more anesthesia. Джорджа, новый наган салсы, демса. И наган сквит джинесал. Траверс. Тратор. Новый АШС per шприц. Yes, it's very important to have a clean syringe to prevent a mistake. Шаршама, сен шаршама. Деген өлең білесің ғой, да, шайхмет? Солай. Шаршама, сен шаршама деген өлең қалай айтылады? Жай?
Кім айтады саны?
Берсін. Инес кейзі сол емес. Қалпағын. Мынаны ішінен алыңыз. Okay, we mix the syringes. Скрытваньяки. Yes, the problem of quotation for the embolization, we can call the patient. For the stenting, he should go for the different places. even in that condition, it's not bad. We still can treat the patients, yeah, for free. But the situation is coming worse and worse. 64 years old gentleman is a... Ана наружный сонда ангиографияны бір көрсетесіз. И нені қойсыз? Глю. Соны текет бесіңіз. Okay, now we will start to inject the... Аға қозғалмай шыдай тұрыңыз. Я соны бір көрсетші. Қанша екен? Yes, I will inject quite fast. And I'm not expecting so much reflux, but we need to keep in mind it could be refluxing. And also it could connect with the different branches, and we can include different territory. Жоқ болмыз, көзге кетеміз. Обратно осы жерге келе жатыр. This patient should yes, it's a different branch. Жақын қолды көзге қарай. Родно персаж. Okay. Yes, on AP it looks like we are quite distal. Awesome. Next. Аға бітіп қалдық қазір. Сәл шыдай тұрмыз. Қазір бітіреміз. Yes, with this severe stenosis in brain circulation, it's better to avoid the general anesthesia. Yes, there is small part remaining. Алдыңғы жағы полный жабылды. Артқы жағында кішкентай бөлігі қалды, оны келесіге алдырсақ. Так, соңғысында стеноз пока терпимо вроде. Мен қолым тиіп кетті. Мына жерге қолым тиді. I will ask Ahmed to do control CT. But before, you need to pull the guiding to the common carotid, do global view, and then do control CT and finish. Okay? Аға біз бітірейін деп қалдық 5 минут бұрын. Шыдай тұрасыз қой, да? Ауырған қазір басылады біртіндеп. Жаңағындай ауырып жатыр ма, оң жақтағыдай? Қазір қояды. Окей. Жасай бер. Клей тұра берсін бұл. Okay, dear colleagues, let's analyze this angio, this control CT. КТ-ні ортаға қоясыз, Ахмет? Okay. Meningioma number 1. I hope we included it. There is a stent in cavernous part, and this is liquid embolic here. This part is still there. We will attack it next time, and it looks like it's supplying from the superficial temporal artery also. Maybe we can proceed from meningeal territory to the superficial temporal next time. And this meningioma is occluded. I hope this meningioma also will be occluded. Okay. Let's see the angio. Шехмет, 3D алып тастайсызшы, ревьюді қоясызшы по центру. Okay. Спасибо. Yes, we already stented ICAT in cavernous part, and then this territory, and there is this territory also. Let's check it. But it was looked like something more frontal oriented. Okay, we will do control. Yes, this part is back part, this part. And this part also connected to the parasagittal region, which is also still feeding. Extracranial IC is stenotic, but it's a question of next treatment. Okay. And patient is okay, he is communicating because it's a local anesthesia. And now we can finish this case and see you in next 25-30 minutes. Next case is ICA aneurysm. See you in 25-30 minutes. Thank you for watching.